Hi everyone. Today's video comes to us from the city of New Orleans, and we'll be taking a look at the case of a 54-year-old female with a chief complaint of shortness of breath. We'll walk through her clinical presentation and discuss how Fick's Law helps explain the interventions used to try to help improve her condition. To begin, we are briefly going to review Fick's Law. And so, of course, Fick's Law is the law of diffusion, and the reason why it matters is because if our diffusion isn't good, we're going to have a deficit. We're not going to have enough oxygen to meet our demand. So the variable we always need to ask is how fast is gas moving across that ACM? And if it's not moving fast enough, what's impeding it, and ultimately what we can do to help. When I was first learning this, one of the most confusing things for me was understanding proportional, directly proportional, and inversely proportional. And so an easy way to remember is that any number that's on top on the numerator is going to be directly proportional. And that just means that as it increases, as the numbers on top increase, as the numerator increases, the flow of the gas is going to increase. And if any of the numbers on the numerator decrease, then our flow is going to decrease. And when we're taking a look at the bottom, the inverse is true. When our thickness increases, our diffusion decreases. And when our thickness decreases, our diffusion increases. And so that's why it is inversely proportional. As this goes down or up, this is going to move in that opposite direction.
So we're going to a 54-year-old female, shortness of breath, who has a history of asthma. Go the other way.
I'm just gonna go straight down the pizza.
It's really, really bumpy this way, though.
I honestly didn't know that. I'm sorry.
Hey, darling. We're gonna get you taken care of. How long have you been short of breath, baby?
Started 2 weeks ago.
2 weeks ago.
But I've been taking everything.
Okay.
I just come back from an event. Okay.
So our patient states that they've been compliant with their medications at home and they've been feeling short of breath for the past 2 weeks. So just an indication that what she has been trying has not been working for her recently. So we expect this patient to be pretty sick because of that. Oh, and look, she has an at-home E-tank with the pin index safety system and the conversion factor of 0.28.
We got it.
You got bronchitis, baby?
Okay.
Come on, keep coming. Yeah, you're wheezing, darling.
I just took a treatment at about 8:30.
The fact that she took a breathing treatment and she's still feeling this way is a huge red flag. We need to get her in the ambulance with her exerting herself as little as possible.
And I've been taking them. I had to take them every 4 hours. And I've been taking them.
Let me see this on, baby.
I'm an Indian, and I was clean for a year. 2 years in a row.
Okay. Is that what you were doing? So that's where you were tonight?
Yes, we select another queen.
Big poke, baby.
Okay.
All right.
Whew. IV in the back of the hand. I felt that one from here.
All done. He said this is worse than it normally is.
So our patient is clearly having some labored breathing. It looks like that despite her having some issues with her at-home medication, they're still giving her a breathing treatment to try to relieve those bronchospasms. So right now, we're working with Fick's Law, where we have those constricted alveoli, or not necessarily alveoli, but just constricted airways in that lung. And when it's when it's constricted, when it's a decrease in diameter, that vastly increases the pressure. So we're starting to help this patient by starting off with Fick's Law.
What's going on, baby? Baby, have you ever had that mask that pushes air at your face? Oh.
So I don't know how long this patient has been on scene receiving that breathing treatment, but one thing that we can tell is that it's not working. She is becoming progressively more short of breath. She's becoming progressively more anxious. When she was walking down the stairs, she was kind of in a light mood, able to have a light conversation. But right now that's starting to turn. She's starting to moan. She's starting to become really anxious. And so what this tells us is that our treatment isn't working. It's not having the desired effect. And so now we need to step it up. We need to try something else. And that something else that we're going to try is CPAP.
Okay, I'm gonna put one of those on you.
She had a lot of fluid in her lungs, and the CPAP pushes the fluid out of the lungs and lets the air go in. You ready?
Do this.
Code 3 University. Time's of the essence with her because she's not getting any better.
You all right?
All right. So taking a look at Fick's law, the two things that we're doing to try to help this person is that CPAP device, of course, gives that positive pressure. And so that positive pressure is helping to splint open those collapsed airways. She probably has some atelectasis. That atelectasis leads to that decrease in ventilation. The other thing that was noted by one of the paramedics is that she said that there was some fluid in the lungs. And when we have fluid in the lungs, we have some membrane thickening, right? And when that fluid is there, the condition is now diffusion limited, which means that one of the biggest problems this patient is experiencing is not necessarily the ventilation getting the oxygen into the lung, which is probably part of her problem, but her biggest problem is actually that there's fluid that is in the ACM area that is limiting that oxygen from being diffused through. So when we give CPAP, we actually can push that fluid back into the circulatory system and basically just try to push it out of the lungs. And when we do that, we remove it from the alveoli, and then the oxygen can diffuse way easier because oxygen cannot diffuse through water. Notice though, she's still receiving the treatment, the breathing treatment, so we're still working with Blasuel's law. We're trying multiple things at once. This cap right here on the top is the PEEP valve, so you can turn that down to increase that PEEP if you want.
CHF code 3 University.
All right, we're going to take a look at her vital signs real quick. So this is something called waveform capnography. It allows us to understand what our patient's CO2 is without even doing an ABG. It relies on exhaled carbon dioxide. Not going to get into the technicalities right now, but some of the things I'm looking at is that her CO2 is 50. So she's starting to get tired. She's starting to enter ventilatory failure. Heart rate is tachycardic, which is expected for a patient like this. Again, trying to offset that hypoxemia. It's probably hypoxemia in her case. And then down here, her blood pressure is high, 165/82, and hypertension is something that is expected in flash pulmonary edema with the congestive heart failure that she's having.
Keep your eyes open for me. I need you to keep breathing, okay? Take a big deep breath for me. Big deep breath. You got this.
Time of the essence with her. She's not getting better, she's getting worse. I'm driving like crazy. I know Landon's in the back, doing everything that he can do.
Hey doc, this is Landon on 3215. I have a 54-year-old female patient. Chief complaint, shortness of breath, history of asthma, inspiratory, expiratory, wheezing, throughout, extremely labored breathing, 45 times a minute.
All right, so when we first put on the CPAP, our CO2 was 50, now it's 34. Her blood pressure is coming down a little bit. She's having a narrowing pulse pressure. And so when the pulse pressure becomes more narrowed, basically it's an indication the heart is having a hard time circulating that blood. Right, so not only do we have a diffusion issue, but we also have a cardiac output issue in this case. The reason why her CO2 probably came down is that earlier the paramedic said that she was taking some intermittent breaths and then had some periods of apnea. So probably what was happening is she stopped breathing for a moment, the CO2 started to climb, and then when she had some spontaneous breaths, those breaths were quick because she's trying to catch up on the oxygen that she's losing. So when her respirations began again, she was probably tachypnic or hyperventilating.
Right now I have her on a duo nev, and I'm giving 125 with volumetric. Would you like me to hang 2 grams of mag and 250 over 10?
All right. So I can't remember if I talked about this or not, but the other thing we're doing to help this patient when it comes to Fick's law is we're giving FiO2 through that CPAP, I'm assuming. And so the difference between P1 and P2 is going to increase. P1 is the amount of O2 that is in the alveoli itself, and then P2 is the amount that's across the ACM, of course, in that arterial blood. So the only way to increase our PaCO2, P-little-a CO2, is to increase the pressure of oxygen in the alveoli, because if the oxygen isn't here, it can't diffuse here. But when we turn up the oxygen here and we push it across, we're going to have a higher rate of success in diffusing and getting the patient the oxygen that she needs.
Thank you, doctor.
Nothing I've given her is turning her around. She's continuing to decline.
So again, we're giving some mag sulfate. That is the smooth muscle relaxant. So it's basically just relaxing the smooth bronchioles in those lungs and trying to make those tubes a little bit wider so that duoneb can reach further down. And then this patient, we want to do everything we can to expand her airways because it sounds like she's having some pretty bad spasms, some pretty bad bronchospasms.
Both medications that I'm going to put into that nebulizer treatment are going to dry up secretions and try to loosen her lungs up a little bit.
Hey baby, how you doing? You doing better or worse? Okay, keep this. Can you make a fist with this hand for me? Make a fist with that hand. Oh, TMS University. Hey, this landed on 3215. Be advised, you may want to have RSI set up. She's getting more and more fatigued.
So our CPAP is not helping our patient, and so our paramedic here radioed into the hospital and let them know that they might want to be prepared to intubate this patient upon arrival.
I radio the hospital and let them know that this patient is
on 3215. Be advised, you may want to have RSI set up. She's getting more and more fatigued.
I radio the hospital.
Man, look at that IV though. That thing was like a laser. Where was that a few minutes ago when he was doing it in the back of the hand?
I'll let them know that this patient is critical. They are spiraling down and they need to be prepared to RSI her as soon as we walk through those doors.
Wake up for me. Wake up.
I can see here that the CO2 has climbed back up to 50.
Baby, open your eyes. Wake.
So when we're thinking about how altered our patient is, when we first saw our patient, she was walking with some difficulty, talking with some difficulty, interacting with her environment. And so as she's becoming sleepier, we call that becoming altered. Her mental status is starting to change. Her sensorium is starting to change. So we have the Glasgow Coma Scale. And so this is used not just in trauma, but to evaluate the level of consciousness in all patients. And so the max score someone can get is 15. So when someone has a GCS of 15, they're going about their daily activity with no issues. And so this patient, when we look at when she opens her eyes, she's doing it to pain, right? Our paramedic is rubbing on the chest, called a sternal rub. She's kind of opening her eyes to pain, so she gets 2 points there. She says words when she has to, right? Like, hey, I'm feeling worse. But sometimes she's making some incomprehensible sounds. So we could give her like a 2 because she doesn't really know exactly where she is or what's going on. There's no indication of that. She's moaning when we rub her, right? And then we have no motor movement. So I would give this patient a GCS of 5, which is really low. Just indicates that we have a problem. Again, GCS is normally 15.
Wake up. You okay? Keep your eyes open for me. I need you to keep breathing, okay? Take a big deep breath for me.
She starts slipping in and out of consciousness. She'll go out and then wake up and take a couple more breaths. There's no extra time here.
So this is the end of the video. It's safe to assume that this patient was put on a ventilator. The main reasons why is because it's going to reduce the work of breathing. Right now, she was still breathing on her own intermittently, but again, she's getting real tired, so no reason why the machine shouldn't do that. And then also that ventilator is going to provide that PEEP needed to help further diffuse that fluid in the lungs across back into the circulatory system. And then of course it's going to help splint those airways open, those closed airways open. So it's going to be adding some PEEP. Awesome. So that's it for the video. One thing I did want to mention though is that in this particular case, despite the interventions, the patient did not get better. And sometimes that happens. There's only so much that you can do. At the end of the day, the patient has to be well enough in order to basically accept those interventions and make the most of them. Sometimes people are just too sick, but if you know that you did the best you could and that there was nothing wrong with your treatment, if the outcome was still poor, you can still hold your head high because there's nothing wrong with that. That kind of thing happens. All right, guys. Well, thank you so much for watching. I'll see you later next week after Christmas.